that could really hurt you. So try to be very honest with the clinician about how much benzodiazepines you're using. First thing you want to do is address what you can and mitigate risk. Hi everybody, welcome back to the channel. This is Dr. B, Addiction Recovery, and today's topic is going to be the trifecta of addiction: opiates, stimulants, and sedative hypnotics or benzodiazepines. Usually this is heroin or fentanyl, nowadays fentanyl, methamphetamines, and benzodiazepines, Xanax or otherwise. Let's get started. This is a really important topic, as I've mentioned in other videos, and if you follow me on a regular basis, you'll know that I really have been pointing out that the landscape of the substance abuse patient, the client, is different today than 30, 40, 50 years ago. Traditionally, someone presents with opiates or someone presents with methamphetamines or stimulants, cocaine, crack, speed, or someone presents with benzodiazepines or alcohol. Today's environment is vastly different, and the cultures of the drug addict or addicts is really different. It's all meshed in together. And this creates a lot of complications and not knowing what to do for the typical practitioner, as well as the systemic, fundamental, institutional structures that we have set out and the forms of payment for the drug addict going into treatment. They don't know what to do, and they have limited amount of time, and there's this push and pull between the insurance company and the provider or the provider setting to collect funds, and this creates problems and barriers in appropriate treatment that could be deadly for you if done wrong. In addition, I feel that most providers don't really have a solid algorithm for approaching this kind of patients. And finally, I will say that most of these patients nowadays, although there's the detoxes and treatment centers and residentials that you go in, I would argue from clinical experience that we would save a whole lot of money and have much better outcomes if there were more freestanding substance abuse clinics. In the same way there's a diabetic clinic, there's a cardiology clinic, there is a musculoskeletal clinic, there's an immune disease clinic, endocrinologists, and so forth. A secondary clinic should also be a substance abuse clinic. And that's why I advocate, and that's what I run. In addition, I think for you to listen to this whole thing is critical, because understanding how you should be cared for and the care you should be expecting that needs to be provided is fundamental for your long and short-term outcome, including relapse and even, God forbid, death. Let's get started with this now. A patient comes to you and they often have now, I'm using fentanyl, I'm using some sort of stimulant. Nowadays, it's usually methamphetamines. It might be mixed together or otherwise. They might chase it. They might do it at separate times. They might do it 2 or 3 times a week. They might do it regularly with their opiates. In addition, they may be taking 2 milligrams, 4 milligrams, 6 milligrams, 8 milligrams of Xanax per day. This sounds like a lot, but this is your typical patient nowadays. And they present to you. I'm going to describe right now how I would treat such a patient and what I feel that the literature and the ruling bodies and recommendations and guidelines would expect of you in the way that you treat such a patient that presents to you. I, or the clinician, really, should not be inhibited by issues of payment, the amount of time they can get the insurance company to cover while the patient is in treatment. And that's why for a lot of these patients, outpatient medical office visits work, and you can do it literally for pennies on the dollar. You get a patient like this, you look at the patient, and you sort of evaluate how much use there is. And usually, because of the physiological dependence, because of the cravings, because of the severe withdrawals, opiates are the leading primary substance of abuse, and that could be a diagnosis as well. It just works out that way most of the time, okay? Really about 98% of the time. So they are using daily fentanyl, for example. In addition to that, they report to you that there is also methamphetamines involved. Always, always, the clinician or the provider should double up the amount of methamphetamines that is being reported, because it's not necessarily a malicious thing from the patient or the client, but they often tend to minimize the amount of methamphetamines, the amount of stimulants they're using. And they even go on to tell you that, I could do without it if I get rid of the opiates. That may or may not be true. It's irrelevant. But they're reporting to you daily fentanyl use, some or a lot of stimulant use, usually methamphetamines. At times, they are mixing the two together, chasing one after the other, usually the methamphetamines afterwards. None of that matters. There is abuse of both of those. In addition, they go on and report to you a history or current use of benzodiazepines, sedative hypnotics. And usually, most of the time, that is Xanax, but that's also irrelevant. And the clinician should be really cautious in interpreting the amount of Xanax or sedative hypnotics used, because that is also often minimized. That's what patients tend to do. With this last part, the Xanax or the benzodiazepines, the clinician should work really hard to get a real amount of use on paper that they are certain and secure about. Why? Because the patient could die or get very sick if they don't get it. So if it's dismissed by the clinician how much benzodiazepines you're using, that could really hurt you. So try to be very honest with the clinician about how much benzodiazepines you're using. You're in there for treatment. Don't minimize anything. It's a very complex, multifaceted issue that you're dealing with that affects multiple areas of your life. And there's no sense in lying or minimizing or completely dismissing your complete issue when you present it to the clinician. And often this comes out because they'll be telling me, I use Xanax sometimes, and then they'll tell you, they've lost their license because of a seizure, or did have a seizure in the middle of a mall, etc., etc., etc. Or they'll tell you they're on Keppra, which is an anti-seizure medication, and you'll ask them, what is the cause of your seizures? What is the diagnosis? And they'll tell you they didn't know. Well, you may have not told them that you're taking in a whole bunch of benzodiazepines and you suddenly stop. So in short, the patient presents to you and their leading drug is opiates, usually fentanyl. Then there's a methamphetamine involved, and a benzodiazepine. How do you approach that? How do you categorize that in terms of importance? Do you treat it all at once? There's no medication-assisted treatment for the other two. Should you just have them stop completely? Should you not see them and make a contract and say, okay, I'm going to put you on buprenorphine products or methadone, but if you use any of those other things, you're fired and dismissed from the clinic? Should you immediately address the methamphetamines first? Should you address the benzodiazepines first and make them stop? Here's how I think you should do it, and here's what I think the literature supports, as well as all the guidelines. You take a look at every single issue that the patient has, and you start automatically in your mind doing a risk-benefit analysis of every action you're going to take as a clinician, the resources that the patient has, their ability to maintain and go along with your plan of care, okay? In addition to the fact what resources are available to you. Opiates. We actually do have wonderful medication for the opiates. Let me add one more thing to that. Once you've done all of that, you have to be thinking as a clinician that behind this substance abuse, behind this need for opiates, for stimulants, methamphetamines, cocaine, speed, besides the fact that they have this need for benzodiazepines, underneath all of this, you haven't even touched the fundamental issues that got them there. It might be severe anxiety. It might be panic syndromes. It might be depression. It might be some sort of an axis 1 disorder or disposition on a spectrum. It might be severe sleep issues. And then underneath all of that, you have to be thinking in the back of your mind, what were the traumatic events in this patient's development from childhood that sort of are the fundamental framework for the anxiety, for the depression, for the panic, for the lack of self-worth, for their inability to cope with internal influences in their life and had to turn to drugs. So the clinician should be thinking of all of those things. And in their treatment, they should be peeling layers of treatment and dishing it out to you piecemeal so you can digest and move forward without judgment and without a sort of accountability and responsibility which you're going to fail at. So how should you really approach this person? Let's just take the most surface level, the substance abuse. There's 3 of them: opiates, stimulants, and benzodiazepines. First thing you want to do is address what you can and mitigate risk. Fentanyl can kill. It does kill. A couple years ago, the numbers were over 100,000. The first thing you should do as a clinician, and I think this is what your clinician should do when you go see them, is get the person started on medication-assisted treatment and spend the next couple of weeks, couple of months, however long it takes, to get the dose just right and stabilize them at that dose. You certainly don't tell them to go on and, oh yeah, no problem with doing meth, but you want to really give them some really professional, motivational support to start working with you to change things along the way. So you want to address the opiates first, and then you want to spend the next couple of weeks making sure you get them on board on medication-assisted treatment. If you can do this, you will unmask a lot of anxiety, you will mask a lot of depression, and you will get a sense of where their stimulant use is truly at. Okay? They might completely stop using methamphetamines, or they might decrease it, or they might even continue to do it. Doesn't matter, you'll address that as it comes along. But first you want to get rid of the opiates and have a replacement therapy, allow unmasking of what I call supertentroia or their psychological disposition with their disease and pathology, both in terms of mental health and their physical body. While you're doing that, at the same time, you want to really get a sense of their benzodiazepines. And this is where a lot of clinicians fail, and also where there is a lot of misinformation and misunderstanding by the public out there. They think if you're on Suboxone, you cannot be on benzodiazepines. Okay, so what are the choices here, right? Guys using 10 milligrams of, so that's not true, number one, and the guidelines tell you that you should approach it with thought, clinical care, consideration, and safety of the patient with education. If they're on 10 milligrams of Xanax a day and they're using a gram of fentanyl every day, what are you going to do? Choose which one you want to address? And how quickly are you going to get them off of 10 milligrams of Xanax if they've been doing it for 3, 4, 5, 6, 7, 8 years? You're not. So the way one should approach it is get them on medication-assisted treatment. At the same time, get them to stop buying products on the streets and pressed medications, because you're really taking a chance at your life when you're doing that. Convert the Xanax, okay, and do a cross tolerance to whatever you want, Klonopin, Valium, so forth. And I usually do Klonopin. And start managing those 2 things at the same time. And you don't give them a prescription and say, see you in a month. You get 1 week supplies, 3 days supplies, 5 days supplies. You need to watch the patient, make sure they're safe from themselves, make sure you give them guidance, make sure you really steer the way the treatment goes. At the same time, you need to take care of their physiological issues and any possible complications that may arise. So you give a really short dose, both of your medication-assisted treatment, as well as cross-tolerance and getting them off of street Xanax. Meanwhile, you watch the methamphetamines closely. Usually with patients when they come in, and this is where other providers might not be doing it, and they really should start to do this, you do not write a month's prescription and send them out. At most, initially for a patient like this, it's 1 week. If you do this correctly, sometimes it takes 1 shot, sometimes it takes 4, 5, 6, 7, 8, 9 shots. The key is to, during this time, you have to build a professional but very tight rapport with the patient where they feel that when they come into this clinic, they are safe, they are not going to be judged, and they have a sense of emotional well-being and potential safety and anchor for the future. This is the only way I believe clinicians can be successful for treating an extremely complex polysubstance abuse issue. As time goes on and you're making headway, you're starting to get know the patient at both a physical, physiological, emotional, psychological, and social level. You start to know their nuances, their limitations, their relationships. And during that time, you start to develop secondary psychiatric or mental health diagnoses, and there are other issues as well. If there's abscesses to be dealt with, if there's soft tissue infections, if there's housing issues, social stuff as well. And you start addressing those other issues as well. For an example, let's say you're 3 months into this and you really have the patient at a stable dose of benzodiazepines. They've really stopped their methamphetamine use and it's been over a month and a half. And buprenorphine is at a perfect dose that you think works for the patient 24 hours a day, 7 days a week. But they're still having sleep issues. Now you can address that. Maybe a little mirtazapine, whatever that choice happens to be at that time. What I've described to you, I think, is extremely important for you to really understand and digest, and maybe watch this video a couple of times. And this is what you should be expecting from your provider or team of providers. And I really believe that for the most part, most of your care should come out of the same place, same facility, same provider, same group of providers. This is how care used to be. This shows long-term benefits for chronic diseases, whether it's lower back pain, chronic pain in general, or substance abuse. You need to build a home base and grow from there and move on to your recovery with the hope that in time, however much time that is, you will have the tools to deal with the world around you and succeed in the way that you see fit. Thank you very much for watching this video. I hope this gives you some information that's not out there. If you did like it, I'd love a like button, I'd love a subscribe, and consider our Patreon. Have a wonderful day. Peace.